came out, it was very clear with me that this should be anatomy rather than the operative side. So in a tribute to Professor Roton, most of my slides will be from that fantastic Roton collection that Bill just highlighted, the work he and Jeff Sorensen had done to get this available. And I would strongly recommend this collection to anyone interested in neurosurgery. It's just an absolutely fantastic archive of all of Roton's works. And most of my slides today as a tribute to Professor Roton or my talk on the anatomy will be based on that. So I'm going to cover some of the real basic anatomy. I know we have a lot of residents and students and things joining webinars. So a lot of what I'll be talking about today is the basic anatomy. I'm going to start laterally, moving medially in until we get to the carotid. We'll take a view posteriorly, we'll take a view anteriorly of what the cavernous sinus looks like and talk a little bit of some of the principles when operating there. We'll talk about the sort of two major approaches. Most of that was really well covered, obviously, by Professor Dolenk, who really introduced us all to this field. And really everything you needed to learn about operating there, you heard in Professor Dolenk's talk. And I'll just follow off the principle of what he said, where you have to understand what's next to you if you're going to operate here. I agree fully with Bill Codwell that we should all be operating in the orbit. I consider the posterior third of the orbit to be neurosurgical territory. And actually, I quite like coming down the medial orbit, either endoscopically or displacing the eye, or in very malignant tumors or fungal infections when there's an exenteration, an extension into the cavernous sinus. I think coming down the medial orbit is a fantastic approach into the cavernous sinus. But most of what I'm going to focus on today is that lateral approach, a very standard approach into the cavernous sinus. As we all know, it's this venous structure here, and I as a tumor surgeon, like to think of it as pockets. Venous pockets that you can work in, and then you can pack off as you remove tumor, and work very safely to completely remove usually soft tumors in this location and protect the cranial nerves. And this, of course, is a beautiful aerial view. We're looking from the top down into the orbit, how the cranial nerves cross into the orbit. I'm going to stop at the suborbital fissure. Pablo has previously covered beautifully the anatomy in the orbit. So I'm just going to focus here on the sort of basic anatomy in the cavernous sinus. As I said, everything you really needed to know about operating there, you saw in Professor Dolenk's talk, which is beautiful. And my favorite approach, you've previously heard me talk about coming into the cavernous sinus posteriorly by cutting the tentorium and opening into Meckel's cave from the back. But today we're going to talk about the terional and sort of middle fossa approaches into the cavernous sinus. So whatever incision you'd like to use to get in a terional and down in the middle fossa. And then you have to understand that where either the suborbital fissure or at V2 or at V3, these are the locations where you can separate the dura propria, the meningeal dura, from the periosteal dura, and you can then get beautiful access into the cavernous sinus. You've seen lots of videos today. Pablo had a very nice video as well, coming in at V3, which I think is when you're starting out, it's actually the easiest place to get into the cavernous sinus. So all you need to know about operating the cavernous sinus is understanding those two dural layers, and I'll show that schematic right at the end, about separating between the dura propria and the periosteal dura, and how that gets you beautifully in the cavernous sinus. But of course, once you're there, then there's a question about the pathology there and the anatomy of what you see in there. And I just want to go through that again. Salman covered some of it, and I just want to build a little bit on that. So these are the sort of things, and these are all cases, I've operated on where there's been extension into the cavernous sinus, and I don't necessarily always chase the tumor in some of these cases into the cavernous sinus. So I think soft tumors do really well. So this is a chordoma, and you can get a beautiful complete excision here, including of the cavernous components. So you have to understand how to come medially into the cavernous sinus. You have to, and get into that, but here's one where you would come laterally. This is a trigeminal schwannoma, a small trigeminal schwannoma. I actually think the bigger ones are a bit easier, but how you separate at V3, protect V3, the patient should be neurologically intact in all of these cases at the end of the operation. And you can remove a trigeminal schwannoma nicely. This is another chondrosarc, and how it sort of does that Kawase drilling for you in a lot of these cases. And you can just follow the tumor backwards. This is a cavernous hemangioma. This is a meningioma. Now, meningiomas are the one tumors I don't chase into the cavernous sinus. I think for me anyway, I think the outcomes are poor. But you have to understand there's going to be small remnants that are still inside. They're not always purely a lateral wall. And understanding the anatomy is important for that. And I'd favor just removing this sort of lateral component. Here's an example where it's gone forward. And again, I tend not to chase these petrous meningiomas into the cavernous sinus. So soft tumors, I would advocate trying to get a complete removal. I think it's safe. You can get it out nicely. Not so much in meningiomas. And that's just showing you can get small residual there, but you can get most of these cavernous tumors, cavernous hemangiomas outside. But the reason I put this slide in is you then have to understand what's truly within the cavernous sinus, like a cavernous hemangioma. You have to understand what is then in a sort of intermediate layer, like a trigeminal schwannoma, that has the nerves tend to have what some people refer to as this sort of inner layer around the nerves. And so then they're now between the dural layers, and these are probably the best ones to start with when you're starting operating the cavernous sinus, and actually very straightforward with good technique, very straightforward to remove. So you have inside, truly within the cavernous, then within the dural layers, and very straightforward to remove. And then tumors that are on the outer layer, and you can see how you can get very nice resections of these tumors, relatively straightforward to do. There'll be little bits within the cavernous sinus that I tend to leave, but everything on the outer layer of the dura you can remove. And then the final thing when it comes to cavernous sinus and understanding the blood supply, so this is obviously sphenoidal meningioma, some attachment of the clinoid and cavernous sinus, but I think really understanding the vascular anatomy, and very nice talk from Jack earlier, talking about why vascular is important for skull base and vice versa. But understanding that vascular anatomy, I think, is important. A lot of people feel maybe it's not, because the dura supply is going to end in the dura anyway, but I think it's actually really important. This is an incredibly vascular tumor. I think it's almost 6 centimeter tumor. Huge flow voids the size of the middle cerebral artery within the tumor, but you can safely take these out, I think, with a good understanding of the branches that supply this. It'll come from within the orbit and within the cavernous sinus, and that all comes from this basic anatomy of the cavernous sinus. You can get very, very complete resections, very, very safe resections. Patients do very well and are neurologically intact from having a good understanding of this anatomy. Okay, so let's start, and I'm going to use the Roton slides. As Bill said earlier, there's a fantastic resource in the Roton collection, which I would hugely recommend. I look at it all the time myself. I think it's just fantastic. So you have to understand, so we're looking at the right-hand side here. All of these are from the Roton collection. And as Professor Dolenk said very nicely, if you're going to operate here, you have to understand what's next to you and what's next. So first of all, lateral view, looking into the right side of the cavernous sinus, brain obviously has been removed. Very simply, you first have to understand what the borders are. Okay, so you have to understand anterior clinoid process. You have to understand tentorial edge as the superior border. You have to understand, once the dura is removed, you see a better superior orbital fissure going anteriorly. You have to understand inferiorly, there's Meckel's cave and the maxillary branch of the trigeminal nerve. And certainly laterally anyway, you've got the superior petrosal sinus posteriorly. You can see third nerve coming in. We'll see it better as we start to strip layers away into the roof. You can see the fourth nerve coming back posteriorly into the tent. And as skull base surgeons, that's important for us. We routinely will cut the tentorium and all sorts of approaches, either this way, coming anteriorly, or coming from the back posteriorly and cutting the tent, and understanding the superior petrosal sinus and the fourth nerve, and cutting behind it is very, very helpful. So that's that initial layer stripped away, and you start to see, in my view anyway, and of course, if you've got very experienced surgeons here, Professor Doll and Professor Gold, they can tell us. But my view is that there are compartments in the cavernous sinus, at least definitely medial and laterally, and I think even more than that in the tumors, and that's what allows you to work nicely in these compartments, remove the tumor out. But we're starting to see that outer layer has been stripped away. You're now seeing a beautiful view of third nerve coming under the clinoid. Professor Dolenk showed some beautiful, we'll see some views with the clinoid removed, but just some beautiful intraoperative views of how removing that clinoid gives you fantastic access in. And that's definitely true for a lot of skull base and vascular work. But we're focusing on the anatomy here. You've got third nerve as it comes in, and you'll see as the clinoid, well, actually, you can see probably better in the next picture, but one thing you start to see is this oculomotor cistern here. And so you can open from the edge of 10 if you wanted to the tip of the clinoid and chase tumors within this oculomotor cistern if you wanted to. There is a small area there which is very reasonable to go into and chase small amounts of tumor if that was going to give you a complete resection. Fourth nerve coming in, and then this sort of arachnoidal layer over the trigeminal ganglion, the various nerves. Ophthalmic veins and things will drain backwards here. You can see some of the drainage further back in the superior-petrosal sinus. We'll remove the clinoid soon to look at the carotid, optic nerve, and clinoidal carotid. Just like taking that arachnoidal layer away again, you see that oculomotor cistern quite nicely that I talked about, where you can come in and start to chase tumors. You're starting to see the middle meningeal and the GSP end, marking where the carotid will be. Middle meningeal is a really useful landmark when you're coming in middle fossa approaches to picking up V3. And I said V3, or the maxillary branch, is a fantastic place to then enter into the cavernous sinus. And if you're starting cavernous sinus surgery, I think that's a really good place to start going for some of these soft tumors. Same view again, where we're just peeling back the layers now, and you're starting to see the course of the third and fourth nerves, and you're starting to get an idea of the carotid. We'll look at the carotid in more detail, and as Professor Dolek said, understanding the turns of the carotid, I think, are really, really helpful for surgical planning and what you're going to encounter when you're going to go into the cavernous sinus. We're just sort of slowly peeling layers, and now we're starting to see what 3 and 4 do, and we're starting to see the 6th nerve as well, as it's medial to the ophthalmic division of the trigeminal nerve. Obviously, this is the maxillary division going to rotundum. I'm not going to talk about that today. I've spoken about that before, but you have to understand the anatomy here in rotundum, particularly coming endoscopically, and what happens in the tragopalatine fossa, a lot of which nowadays we don't approach laterally. We would come endoscopically for that. Okay, so Salman touched a little bit on this, but this is now starting to piece together what we see laterally with what we see posteriorly. And here, an important structure here that what we see in a number of different approaches, and a lot of our complex endoscopic approaches we see in the CP angle, but you have to understand what the 6th nerve is doing. And there are 2 sort of important ligaments. We'll talk about the petrolingual ligament in a minute, but now we want to talk about petrosphenoid or Gruber's ligament. And that's very important to understand when you're sort of doing these sort of Kawase type approaches, this posterolateral triangle, and how the 6th nerve is coming over and its relationships to the basilar plexus, and how it comes over the inferior petrosal sinus. So this is it just from different views. This is the view from the side, the view we've been looking at the whole time. You see the carotid there, that's 3, that's 4, V1, and you're seeing 6 medial to that. And you have to understand this, both when you look this way, you have to understand when you're doing posterior petrosectomies and things and you're coming the other way, and that's really important. So this view here is just pulling down the trigeminal nerve just to give you a better view of that. But this is the more important view here. So same view again. This is the petrosphenoid ligament, and you can see how the 6th nerve goes up, and you can see some of the posterior drainage coming out of the cavernous sinus there, and how the 6th nerve comes above the inferior petrosal sinus. So really important view to understand how the 6th nerve goes back. You can see it's in relationship tighter to the carotid there, and that's important. Some of these tumors, usually when you're doing trigeminal schwannomas and things, you're very safe, you're protected by the trigeminal nerve. You definitely keep the trigeminal nerve intact in those operations, but you have to understand what structures are next when you're as you're taking the tumor off. Okay, and then maybe less so now in terms of the vascular work, but there has to be some understanding of the various triangles and the sort of entry zones that gives you into the cavernous sinus. And here the dissection has gone further. So before I talk about the triangles, you'll see what the medial borders are. with the sphenoid sinus, you're starting to see, including the floor of the sphenoid sinus, GSPN going forward as the Vidian and how that relates to the carotid. And we'll look at that again when we look at the anterior view. The other important thing here, of course, is that we're now seeing the clinoidal segment of the carotid very nicely. So the enteroclinoid process has been removed. And that's the first triangle here. So you got the proximal and distal dural rings. And strictly speaking, if you're talking about the cavernous carotid, it's really between the petrolingual ligament up to the dural ring. And those are strict borders of the cavernous carotid. So if you're thinking about working strictly within the cavernous sinus, that's what you have to think of as your borders of the carotid. And the rest of it obviously is outside. You have the clinoidal carotid here, and that's was an important location in Oxford. We moved a lot to endovascular treatment for a lot of open surgeons. That's still an important area. This sort of clinoidal triangle here giving you access to the carotid. And a lot of these triangles give you good access to the carotid, but also for some of these tumors into the cavernous sinus. So now we're looking at the next triangle here. That's between the third nerve, oculomotor, and the trochlea. So this is obviously the supratrochlear triangle. I'll show you another picture that shows the dorsal artery of the carotid coming off there. Coming below, you have the infratrochlear triangle. And then coming below here, you're starting to get your anteromedial, anterolateral. For me, I use this less now, these triangles, except for Kawase. I think it's been superseded by other approaches and other techniques, but still very important to understand. The anteromedial, anterolateral triangles is now, this is between the ophthalmic and maxillary, then maxillary and, between V2 and V3, V1 and V2. The triangles, maxillary and mandibular divisions. Then coming back, you've got posteromedial, posterolateral, and obviously posterolateral, hugely important. Kawase's triangle is GSPN that divides these two. You have to understand how the carotid lies. At this point, we'll look at the carotid in more detail. And this approach, beautiful approach into the posterior fossa. We've seen some really nice videos already shown today by a number of the other speakers, but fantastic. And for me, great views down to the level of the IAM. I know some people like to go further, but I think from middle fossa down to IAM, Kawase, absolutely fantastic approach. And we'll look at that in a bit more detail. So those are the triangles of access into the cavernous sinus. This is just another view. We're building towards the carotid now. So what we've done here is we've cut the trigeminal nerve out, and there's also been a drilling here in the posterolateral Kawase's quadrangle, really. So just to orientate you, we're seeing some new structures here. So firstly, of course, we've got the carotid. We'll talk about the carotid more once we remove more of these structures here. Third nerve coming in through the roof, fourth nerve coming back in through the tentorium, ophthalmic division, maxillary division going to rotundum, mandibular division going to ovale, foramen spinosum, and middle meningeal. Key landmark that when you're coming middle fossa allows you to identify V3 and then get into cavernous sinus. And then once you've sort of separated out, then you can expose this posterolateral triangle. Here there's been some drilling into the cochlea, usually try and avoid that unless you really have to. But here you're looking into the IAM. So absolutely beautiful view of the seventh nerve. Superior petrosal sinus has been cut. You've got seventh nerve coming to geniculate ganglion as it turns backwards, gives GSPN going forward, which will join the deep petrosal nerve to become the Vidian. And you've got the semicircular canals. And obviously, these are hugely important landmarks in the posterior petrosectomy approaches and translab approaches to the IAM. But today we're talking about coming anteriorly and the anatomy coming anteriorly. Important to understand. Yes, sphenoid sinus is here. Sorry, Pablo, do you?
1 more minute you have, sorry.
I'm going to go a lot quicker then and skip forward. The other key landmark really to understand here is the petrolingual ligament and its relationship to foramen lacerum. Lacerum and things you can see very nicely on your CT scans. And so understanding the petrolingual ligament all the way to the dural ring, it's your cavernous carotid and its relationships here. And if you're going to operate in this area, that understanding is critical. is just to show the major branches, meningo-hypophyseal trunk. Another picture here of the infralateral trunk, which are the major branches coming off. Meningo-hypophyseal is the key one to understand really for a lot of the skull base cases. Gives you the things like the dorsal or clival artery supplying the clivus here in the infratrochlear. This is just the venous drainage coming backwards, but the other important view then is to look anteriorly and get the same understanding anteriorly. So carotid is here, you've got vidian, you've got rotundum. I'll skip forward. I've highlighted, or actually the Roton collection has highlighted the clival carotid. And you should really understand how this is going towards rotundum, your sixth nerve, third nerve, and ophthalmic division all relate to that. And just a deeper view of sixth and the various nerves that we saw laterally, but now you're just seeing them medially, and you must understand both of that to operate on these tumors. That's just the Kawase again, and how you can understand the carotid and how tumors wrap around it is really important. You get very nice and very straightforward. I'll skip the video. Very easy to get once you understand that. Very straightforward resections. They're soft tumors, they come out very nicely. But if you're going to start on cavernous sinus surgery, this is a paper because a nice illustration of Professor Kawase, but described beautifully by Professor Dolenk, Professor Hakuba. You must understand the various layers. That is the key to doing these operations. V3 is the best place to do it. You have to understand that there is a periosteal and a meningeal layer, and even an inner layer protecting the nerves. You can separate these layers. You can get in beautifully and easily debulk tumors involving that. It's a good place to start for cavernous sinus surgery. You saw some nice videos from my colleagues earlier showing some very, very nice operations in that area, but this is the key anatomy to understand for that. And then beyond that is the anatomy I showed earlier. This is just to show you can take these tumors out, patients are intact, you get complete resections. It's very nice, very straightforward. Okay, well, thank you very much.